by forever mental health specialist infinitist too. Boo, ahoo. Stigma against mental illness is a scourge with many faces, and the medical community wears a number of those faces. But that is what these people do. The Steves of this world, they all try and make something out of nothing, and they all do it for themselves. And like Ed Kemper, he was able to convince the psychiatrist he was making excellent progress while he was actually killing human beings. This is kind of a sick version of the old joke about how many psychiatrists it takes to change a light bulb. The answer being just one, but only if the light bulb wants to change. Somehow the disorder hooks into all kinds of fears and insecurities, and many clinicians and the flamboyance of multiple, her intelligence and the ability to conceptualize the disorder, coupled with suicidal impulses of various orders of seriousness, all seem to mask for many therapists the underlying pain, dependency, and need that are very much part of the process in many ways. A professional dealing with a multiple and crisis is in the same position as a parent dealing with a 2 year old or with an adolescent's acting out behavior. Basic misunderstandings about did encountered in the therapeutic community include the following: the expectation that all clients with did will present in a Sybil-like manner with obvious switching and extreme changes in personality that therapists create did in their clients, that did clients have very little control over their internal systems and can be expected to stay in the mental health system indefinitely, that alter personalities, especially child alters, are simply regressive states associated with anxiety, or that switching represents a psychotic episode. Some psychiatric clinicians appear to be so biologically or behaviorally oriented that they do not believe in unconscious. Others have been so intricate, indoctrinated in the Freudian psychoanalytic model that they believe all accounts of incest are fantasy. A few of the older clinicians allow pride to get in their way and refuse to believe that they may have a missed diagnosis of a dissociative identity disorder in some of their patients. And the OCD is like a storm that rages within, but with courage and perseverance, we can learn to dance in the rain. Jesus is not at war with mental health professionals. You can walk hand in hand with both Jesus and the therapist. In fact, you are doing the bravest thing of all by allowing someone in who can walk you through the hard things. We're never meant to go on this journey alone. However, it is important to remember that only 15 years ago, most major training schools did not accept the existence of child abuse and condemned what they saw as the unhealthy excitement that was considered to be from the earliest exponents of the language of their criticism, and very similar to what greets the clinician of today who speaks of did. It has been later knowledge that understands the wave of shame and trauma of abuse become projected into the professional network, leading to splitting and blame. Perhaps did raises problematic philosophical and psychological concerns about the nature of the mind itself. Ideas of a unitary ego would incline professionals to see multiplicity as a behavior disturbance. However, if the mind is seen as a seamless collaboration between multiple selves, a kind of trade union agreement for coexistence, it is less threatened in the face to subject. Though it may be a constant battle, let us not forget the strength and resilience it takes to face our fears and overcome the obstacles that OCD presents. Every step forward, no matter how small, is a triumph worth celebrating. With depression, there is always a plus one. This despicable an individual, be they a friend, family member, associate, acquaintance, and ex who works particularly in healthcare, who would use someone's mental illness against them, knowingly, deliberately, and intentionally triggering them to cause and brain harm upon them. What else could we call this type of person? The mental health professionals have their own blocks, distraction, prejudices, and cultural upbringing, all of which color of a work that they do, no matter how well trained or how much they have done on themselves. Let's bring the men back into mental health, because let's face it, toughing it out in silence isn't the flex it's cracked up to be. Real strength isn't about bottling it up. It's about opening up. Mental health isn't just for one gender, it's for everyone. It's time to ditch the macho act and normalize men talking about their feelings, because emotional wellness isn't a sign of weakness, it's a power move. Let's get real, guys. Taking care of your mind is just as important as hitting the gym. I have schizophrenia. I am not schizophrenia. I am not my mental illness. My mental illness is a part of me. Study psychiatric training still includes far too little on the very serious psychiatric sequelae of childhood trauma, especially CSA, child sexual abuse. There is an inadequate recognition with mental health services of the prevalence and importance of dissociative disorders, sufferers of which are frequently misdiagnosed as borderline personality disorder, or in the case of DID, schizophrenia. This is to some extent understandable, as some of the features of DID appear superficially to mimic those of schizophrenia and or borderline personality disorder. If the mind fits, shrink it, never end it, spit it. Within the mental health system in North America, the borderline victim of severe childhood trauma is usually blamed for their behavior, which is regarded as having no legitimate basis in being self-indulgent. Their trauma history is ignored and not talked about, and they are given as little treatment and follow-up as possible. A hospital in Winnipeg, many staff members expressed the opinion in my presence that borderlines and multiple personality disorder patients do not have a legitimate right to an inpatient treatment, and the outpatient department would not accept patients with either diagnosis. Adoption is a lifelong journey. It means different things to me at different times. Sometimes it's just a part of who I am. Other times it's something I am actively going through. The difficulties in diagnosing DID result primarily from lack of education among clinicians about dissociation, dissociative disorders, and the effects of psychological trauma, as well as from clinician bias. This leads to limited clinical suspicion about dissociative disorders and misconceptions about their clinical presentation. Most clinicians have been taught or assume that DID is a rare disorder with a florid, dramatic presentation, although DID is a relatively common disorder. Observed that only 6% make their DID obvious on an ongoing basis. I am the catalyst to change, rearrange lyrics. There needs to be a nationwide awareness program for all NHS staff to educate them about dissociative disorders. Diagnoses need to be more obtainable with the NHS. People's lives should be placed ahead of funding restraints and bureaucratic red tape. We need minimum standards of care and treatment agreed and implemented within the NHS to end the current nightmare of the postcode lottery, and not just guidelines that can be ignored, but actual regulations.